Great. Thank you very much for the invitation. Good morning, good afternoon, everybody. I'm going to be speaking on the radiation side and what's new and what the data is for using radiation at all and where the field is going. So disclosures are NIH funding. So just a quick overview since I'm the first speaker, and then this kind of shows how radiation fits in. In a resectable patient population, we generally use radiation in the adjuvant setting, you can see on the bottom. In a locally advanced setting, similarly, if we're going to use radiation, it's usually in the adjuvant, but there may be a role for neoadjuvant, which I'll talk about. And then in the unresectable setting, radiation has a role in definitive management. So let me start with thymoma. I'll go to the NCCN guidelines first as far as radiation goes on one slide. Essentially, it should be done by experienced radiation oncologists. Not every radiation oncologist sees these patients, so going to a center of excellence can be helpful. The radiation oncologist should communicate with the surgeons and the pathologists to help to inform target volumes. Radiation has a role in the definitive as well as the adjuvant setting. It is important to register pre-op images. That really helps you to define the target. And generally, we're treating in the 45 to 50.4 gray range for adjuvant. If there's residual disease after surgery or unresectable disease, the doses can be even higher. So what do we target? Well, most of the time we're not treating gross disease because there's not a target. It's in the adjuvant setting. But in patients that do have gross disease or residual disease after surgery, the GTV is what we see. For a CTV, we're covering the clips plus where the tumor was preoperatively with a margin, typically on the order of 10 millimeters on top of that. We're not treating electively for thymoma, unlike potentially thymic carcinoma, which I also don't recommend routinely treating elective nodal irradiation either. We do want to account for motion as radiation modalities have gotten more advanced with IMRT, with proton therapy that we'll hear about. Assessing for motion and accounting for that becomes more critical. And then we add some uncertainty, typically on the order of 5 or 10 more millimeters on top of that. So radiation really can impact the patterns of failure in these patients. So if we're treating the anterior mediastinum, this is a relatively large cohort. You can see a handful of people in red did fail in field after radiation, but most of our patients at MSK fail out of field when giving adjuvant radiation. So, as opposed to 50-50 or even typically more so failing in the mediastinum than the pleura. So doing radiation really impacts patterns of failure. Can it impact outcomes also? Early answers, the early assessments to try to answer this question were based on institutional data, and the data looked promising, at least in the Masaoka stage 3 populations doing adjuvant radiation. Most everyone remained controlled in this series, whereas the failure rates were approaching about a third of the population, if not. Here, several analyses were done trying to answer this on a larger scale. Here you can see generally there's a survival benefit in Masaoka 3 and 4 patients, generally a benefit in 2B patients, but no benefit in earlier stage patients. NCDB was probably a cleaner way to answer this, and this was a nice analysis since it was over 4,000 patients, and essentially exactly half of them got PORT and half didn't. On multivariate analysis, PORT did improve overall survival. If you look at the stages, though, there was a nice benefit in 2Bs or a nice benefit in stage 3s. There wasn't a benefit in earlier stage patients. So, the conclusion of this was PORT is associated with longer survival. These are actually survival curves. But in the absence of randomized data, this may be the most compelling to inform practice that 2B is a good use, maybe 1 and 2A are not. And that was similar findings in the IPMIG database. This was 1,200 patients. Here you can see PORT was used again in about half, 55% of patients. PORT was associated with a survival benefit here for both stage 2 and stage 3, although the survival benefit for stage 2 was bigger. And similar conclusion, in the absence of randomized data, this really should inform practice. So, and interestingly, looking at multivariate analysis, you can see PORT pretty dramatic. It almost doubled survival. The hazard ratio is 0.58, really a bigger effect than anything else other than pathologic stage of all factors assessed in the IPMIG analysis. So I put this together trying to sum up the role of radiation. Really, for stage 1, I would say there's generally no role if it's resected. If it's incompletely resected, I would say re-resecting is preferred. But, in case it's not possible, you can consider PORT. In the stage 2 patient population, there's less data. Uh, if it's incompletely resected, certainly you should consider port. If it's an R0 resection, I would say it depends on other features such as histology or tumor size. Tumor size is incorporated in the new AJCC 9th edition and really is prognostic, and radiation may help to mitigate some of that prognostic effect. For stage 3s and beyond, or certainly the R2 or unresectables, radiation has a big role. So the one thing I'd want, everyone who's not a radiation oncologist on this call to know, and even my fellow radiation oncologists, is we generally think of radiation as a local benefit. You do surgery and then maybe you reduce the risk of mediastinal failure with radiation. Well, in actuality, we're doing more than that. If you look at the NCDB analysis I just presented, if you look at the IMIG analysis I just presented, we're not just reducing the rates of failure, that we do very, very well. We're actually improving overall survival. We typically think of this patient population as relatively indolent cancers, but radiation really can make a big difference in this patient population. We certainly would like randomized data, and there are a couple of trials ongoing getting to the what's emerging in the field. In the UK, the Radier Thymic trial, this is still relatively early in accrual. It's expected to complete accrual at the end of 2029. It's randomizing IMRT or protons versus no post-op radiation. And then similarly in China, the Fudan trial, same time frame, will finish it roughly at the end of 2029. This is also looking at the 2s and 3s, having surgery randomized to port or no port. Now, all of those for patients with complete resections. What about patients with positive margins? I actually think this is a no-brainer population where we should be giving radiation. If you look at the NCDB analysis, looking specifically at margin status, if the margins were negative, there was only a trend toward a benefit. Now, remember that this is, a very sloppy NCDB analysis, and you can't control for everything. But, the survival benefit was certainly much more muted if there were negative margins. There's a pretty dramatic survival benefit with positive margins. So this Fudan trial, second trial, is looking specifically at the incompletely resected patients getting port or no port here with concurrent chemotherapy. This trial is actually nearly completed accrual, so we'll have an answer to this sooner than later, and I do expect it will be a positive answer, hopefully. Now, what about patients that are borderline operable with thymoma? We really don't have a lot of data for using radiation in the neoadjuvant setting. The standard of care really is giving systemic therapy prior to surgery and then reassessing for surgery. If the patient's resectable, resect, and then consider and likely give adjuvant radiation, otherwise give definitive radiation. There is some data suggesting doing neoadjuvant chemoradiation can be a benefit. This is a 5-year analysis looking at neoadjuvant chemoradiation. The freedom from progression was 83%, so nice outcome. It speaks to the fact that radiation can shrink this a little bit more significantly than chemo can, and potentially can make a surgery more successful in a borderline operable candidate. What about completely inoperable thymic patients? Well, this is our experience. We have this in submission and press now. 33 patients that we treated at the New York Proton Center and Memorial Sloan Kettering. 2/3 were thymoma, 1/3 thymic carcinoma. Pretty advanced stage. There were several 4As and 4Bs in this. A couple were recurrent. Large tumor volumes. We treated to high doses with radiation. Only one patient out of 33 had a grade 3 esophagitis. Less than 10% had a pneumonitis. No grade 4 or 5 events. And we actually control the disease pretty well. So we generally say radiation is great at small volume disease, particularly in the adjuvant setting. But these are patients with a median tumor size over 8 centimeters, and a 5-year local control was 80%. So, if a patient is not operable, it's not nihilism, it's not, just systemic palliative treatment. Some of these patients can be cured with definitive radiation. How about thymic carcinoma? Well, a little while back, we added JAMA Oncology, a guideline for appropriate use of radiation in the multimodality management of thymic carcinoma, Stephen Chung and I led. Here, basically for early stage disease, we actually do recommend port. I'll come back to that in a second. Generally not systemic therapy, though, in completely resected patients. In the locally advanced patients, we're generally giving radiation. For all stages, we're generally recommending IRMRT or protons, not 3D conformal. If it's a borderline candidate, we recommend induction chemo. This is an interesting fact. Some of these patients have really dramatic responses to induction therapy. If there's a pathologic complete response to induction, really there's no evidence to give radiation. You can consider on a case-by-case basis in those patients. If they're truly unresectable, definitive chemoradiation should be delivered to 60 plus gray. And then for pleural disease, we recommended a variety of things from pleural metastasectomy to SBRT. I'll come back to hemithoracic radiation in just 1 minute, but we generally would not recommend it off study. Now, coming back to the data in thymic carcinoma as opposed to thymoma in the IMIG analysis, giving radiation, you can see pretty dramatic p-value. Really, probably the most significant factor, more so than even resection status. Getting radiation really does make a difference in the thymic carcinoma population, and that was in keeping with the European Society of Thoracic Surgeon database that the role of adjuvant radiation, certainly a significant p-value here for overall survival. And similar in the Japanese analyses as well, over 1,200 patients, and this one showing that even in the stage 2 and certainly stage 3 populations, there's a survival benefit. Probably the cleanest study to answer this was actually just recently published, Andreas Rimner and myself, as well as several others on this call contributing to looking at the IPMIG database as well as the European Society of Thoracic Surgeon database combined, looking at the role of postoperative radiation. Here was almost 500 patients, and PORT had a significant effect on overall survival. In fact, about a 15% absolute improvement in survival. In patients with R0 resection, stage 3 had a dramatic benefit. Stage 2 trended toward but did not have a significant benefit. If there's an R1 or R2, all stages had a benefit and pretty significant. So, and that held up on univariate and multivariate analysis. So this is the largest patient database for thymic carcinoma, and PORT had a survival benefit for all the R1, R2s, and many of the R0 patients. This is looking at overall survival in the entire cohort. You can see the curves separate pretty nicely. For R0 specifically in the early stage patients, the curves still separate pretty well. And then in the R1, R2, the curves pretty dramatically separate. So, clearly if there's residual disease, radiation should have a big role. So we put this together in a publication a couple of years ago. Some societies like ESMO and THYM recommend PORT for even the stage 1s. We did that as well for the American Radium Society JAMA Oncology recommendation. It is a little more controversial in the T1A Masaoka 1 patients, though. And then just ending with radiation modalities, NCCN recommends IMRT over 3D, and actually protons would be the preferred modality to better spare lung, heart, and esophagus. These patients do have excellent long-term survivals relative to the other lung patients like a mesothelioma, a lung cancer, or a sarcoma in the chest. So, they can be subject to late coronary artery disease, pulmonary fibrosis, secondary malignancies that IMRT and proton therapy can benefit. And those techniques can actually shift the benefit where it's a little more ambiguous in a Masaoka 2, a T1A patient, should there be radiation or not. And maybe with advanced modalities, the risk benefit is more favorable. I will say when you need to deliver high doses or re-irradiation for sure, those modalities should be preferable. What's the reason to consider radiation? Well, again, we can shift the benefit and probably help with reducing toxicity. What is protons? Well, unlike regular radiation that you send in, hit the target, and goes out the other side, protons, you send them in, hit the target, and all the radiation stops. So now the entire heart beyond the target gets completely spared. These patients will never have esophagitis like they would do with traditional radiation. The rates of pneumonitis are much, much less. You can see we can now with pencil beam scanning, the newest version of IMPT proton therapy, we can wrap around targets very, very nicely and really spare the heart well. We compared everything from 3D to VMAT, tomotherapy, protons, and carbon, and the particle therapies really just protect a lot better. Lower doses to the heart and really every area of the heart with protons versus IMRT, and we modeled that based on New England Journal publications of heart dose risk with cardiac event risk when delivering radiation to the heart, that proton therapy can reduce the risk of major cardiac events by 81% over traditional photon therapy. Similarly, we modeled that proton therapy can reduce the risk of secondary malignancies over photon therapy since less normal tissue is irradiated. Our group was the first to do a prospective study with proton therapy in thymic patients. This is a pretty advanced population. both thymoma and thymic carcinoma.
Yeah.
Pretty high doses since patients generally had gross disease or even recurrent disease. And you can see the toxicities was much, much less than we would expect. No grade 3, very, very few grade 2 events, and local control was 100% at 3 years. So just finishing up in the last minute or so, the Proton Collaborative group also looked at this, very, very good outcomes with proton therapy as well. And then this was recently presented in getting ready for submission, over 70 patients across 12 institutions. Again, the outcomes were better than we would expect, especially on the toxicity side relative to photon therapy. And in a pretty advanced population, 92% local control at 5 years. So we're working on a guideline right now, and generally, since protons do have the dosimetric superiority, we do recommend it for many cases in the chest, especially for reirradiation or definitive, or anything where you need higher doses or there's a higher risk, especially for the AYA patient population. And then lastly, there is a concept right now in the Proton Collaborative group looking at a dedicated proton therapy trial for thymic patients. This is going to look at a 5-year major cardiac event rate, and will also follow for long-term cardiac and secondary malignancies as well. So this will give a little bit more definitive data. And then lastly, how do you manage pleural disease? Well, certainly SBRT is an option. What about more extensive disease? We have a trial at New York Proton Center in MSK looking at hemithoracic radiation. Myself and Anne-Marie is the PIs looking at hemithoracic radiation, delivering radiation to the entire pleural surface, looking at radiation pneumonitis and other events. And certainly with protons, you could even treat disseminated pericardial disease as well, though certainly not something we routinely do. So conclusions, radiation often has a big role in the adjuvant setting. I would recommend advanced modalities to try to prevent some of the late complications. In general, no role for stage 1 Masaoka patients. Stage 1 AJCC patients are a little split. Some do and some don't. The higher risk patient population really can benefit, especially if there's R1 or R2, or if they're inoperable patients. I'd encourage people to publish their series on radiation so we can better understand late complications. Thank you.